Hello there. We will talk about retinopathy of prematurity, or ROP, here. So ROP is a disease of the retinal vasculature in preterm babies, as its name would imply. So this is always in babies who are premature. This isn't in term babies. The exact cause of ROP is unknown. However, likely it's due to increased production of VEGF, or vascular endothelial growth factor. And what this does is it triggers vascularization. And so because there's increased production of VEGF in these babies, supposedly, you have abnormal vascularization in the retina. And that increases the risk of retinal pathologies, and particularly retinal detachment, which leads to blindness. But the exact pathogenesis is still not fully known. It affects more than 50% of babies that weigh less than 1,250 grams at birth, and that's roughly 2.5 pounds. And then 10% will go on to develop more severe disease. So there is a continuum in ROP. Not all babies with ROP will go blind, and most of the time ROP is self-contained. I mean, it's not going to go on to blindness. You don't need to do any surgery. It will remit on its own. However, like I said, 10%, they go on to develop more severe disease that will require surgery. So symptoms, this is really a difficult one to diagnose just based on the appearance of the baby alone. The one symptom that you can rely on sometimes, but not always, is leukocoria. And leukocoria, we tend to think in term babies, is a congenital cataract or is possibly retinoblastoma, and that can happen in a preterm baby as well. But in a preterm baby, if you have leukocoria, retinopathy of prematurity should be on your differential. However, not all babies with retinopathy of prematurity have leukocoria, and not all babies with leukocoria certainly have retinopathy of prematurity. So for this reason, that symptoms aren't really necessarily present or staring us in the face, screening is important. And at the end, I'll go over some of the guidelines for how to screen babies for retinopathy of prematurity. And on the screening, there'll be an abnormal fundoscopic exam. And the screening exam is done by a pediatric ophthalmologist. The risk factors for retinopathy of prematurity include, of course, prematurity. So the more premature the baby, the higher the risk. And that risk really goes up when the baby is less than 32 weeks gestation. Low body weight, and that kind of coincides with prematurity, but especially if the baby is less than 1,500 grams, that roughly coincides with that 50% range. So they're more likely to have it than not. As some figures say 1,250 grams, some say 1,500 grams. But there is a point where the baby is more likely to have retinopathy prematurity than not, and that's roughly around that 3-pound range. And then supplemental oxygen. So this is one that we didn't know until recently, within the last 10, 20 years. And so babies who are premature were always given supplemental oxygen, which is good because a lot of them have other problems. However, supplemental oxygen can trigger VEGF production, and that VEGF we now know triggers abnormal vascularization in the retina, and so that is what's thought to be behind the retinopathy of prematurity. So babies who get supplemental oxygen are thought to be at higher risk. Hypoxemia is another risk factor, and so that is kind of counterintuitive because you would think, well, if they're on supplemental oxygen, if that's a risk factor, why is hypoxemia a risk factor? Both high oxygen and low oxygen are risk factors, so you kind of have to straddle a happy medium, and that medium is thought to be around 85 to 90% of saturation. However, you should defer to the neonatologist on that. They're the ones who will know exactly where to keep the baby. Hypercarbia kind of coincides with hypoxemia, and then concurrent illnesses, male sex, and intrauterine growth retardation. As I mentioned, the severity varies. In most cases, the disease will spontaneously regress. However, it can lead to complete retinal detachment and permanent visual deficits, which is generally blindness. So this is the retina here, and this is just, it's kind of splayed out. But the retina, remember, is in the back of the eye. It's where the image projects, and it's on a relatively small area of the retina. But when you're looking with the ophthalmoscope, you're really not seeing much of the retina. You're usually only seeing about 5% of the total retinal area. So, for instance, this is what you would see with an ophthalmoscope, and what you're really only seeing here is about this amount, where my pointer is circling. So not very much. But the retina is relatively large compared to that area. So you have the optic disc, and that optic disc is where all your arteries come out, where all your veins go in, and where the nerves from the retina transmit into the brain. Then you also have a macula, and that macula is a structure. It's a sort of reddish structure, usually with this kind of yellowish halo, as you can see here. And that's where a lot of your rods are. Also useful here to note is the ora serrata. The ora serrata is it's Latin for serrated edge, and that's the edge of the retina. You can see it's kind of this serrated pattern here. So that's the edge of the retina. That's what ora serrata means. Okay, so here's a normal optic disc and macula. So all your nerves that are conducting what you're seeing from the retina transmit into the optic disc and optic nerve. And then here's the macula. So the macula is a structure that contains other substructures, and most notably the fovea. And it's just this red spot in this sort of halo-ish area here. Okay. So note that a lot of these arteries, little arterioles, go into this area. So you know that there's something going on here. All right, so, here's the ora serrata too. You can see this kind of serrated edge. So we divide the retina up into retinal zones, and this becomes a little bit important when we're talking about retinopathy of prematurity. So retinal zones are zones 1, 2, and 3, and it's kind of difficult to, at first glance, to see it and figure out how we're exactly pinning these down, but it can be explained. So zone 1 is this circular area, right, and it's defined as this circular region with a radius of twice the distance from the optic nerve to the macula. So here's the optic nerve, here's the macula right here, and the radius is twice that distance. And so you draw the circle around there. So there's your circumference. And so that's zone 1. So if you go back here, here's your optic nerve, here's your macula, and about twice the distance would be about right here. So you would have your radius would be here, and then you draw your circle around. That would be all zone 1. Okay, zone 2 would be the distance from your optic nerve to the nasal ora serrata. So, the ora serrata on the medial side, and then it would be everything within that circumference, that radius. So the optic nerve to the nasal ora serrata is the radius, and everything within that circumference is zone 2, with the exception of what's in zone 1. So here's zone 2 here. And then zone 3 is everything else, and you can see that makes kind of like a crescent shape. And when ophthalmologists write up their findings, they will refer to both zones and they'll refer to clock hours. And this is pretty self-explanatory. So you've got 12 o'clock, which is superior, 3 o'clock, which is medial on the right side, lateral on the left side, I guess. but it just follows like a clock. So 12 o'clock, 1 o'clock, 2 o'clock, 3 o'clock, etc. All right. So here is those retinal zones. I transferred them onto that picture that we saw earlier. So here's your optic nerve and your macula, and twice that is your radius of zone 1. Zone 2 is the optic nerve to the nasal ora serrata, and there's your radius here and your circumference, and then zone 3 is everything else. So if you have retinopathy of prematurity within zone 1, that's the worst kind, because that's where most of your rods and cones are, where you're viewing things, where the image is projected, and so that's the worst place to have ROP. Now, in addition to where the ROP can be, there are stages of ROP. And I kind of alluded to this earlier, whereas some of the earlier stages, 1 and 2, don't necessarily need to be treated with surgery yet. Stages 3, 4, and 5 are more severe and they require more intervention. So how do we define these stages? There's lots of ways the stages are defined, various features that are present, but I kind of broke this up into the most boiled down definition. And I don't expect the USMLE to ask you about this, but it's good to know the progression of stages just to understand, have a more deeper understanding of ROP. So stage 1 is the presence of a demarcation line, and that demarcation line is simply part of the retina that has vascularization and an immature part of the retina that doesn't have as much vascularization. And you can see a very obvious line that goes through that area. I should just show you a picture here. So this is an example of a demarcation line. So you've got vascularization and no vascularization, and that's a demarcation line. Okay. Stage 2, that demarcation becomes a ridge. So rather than being a 2-dimensional line, it becomes a 3-dimensional ridge. And that will be pretty apparent when you do your formal exam. Ophthalmologist will do it, but just pretend you're the ophthalmologist for now. So instead of a demarcation line, it will be a 3-dimensional ridge. Stage 3, you start to get vascular proliferation. And you'll see that most notably around that ridge. And then stage 4 and 5 are where you start to have retinal detachment. So stage 4 is partial retinal detachment, stage 5 is total retinal detachment. So here I kind of illustrated it for you here. So here's normal. Stage 1, you have the demarcation line. Stage 2, you start to get a ridge, which is 3-dimensional. Stage 3, you start to get fibrovascular proliferation around the ridge. Stage 4, you start to have retinal detachment, but it's only partial retinal detachment. Stage 5, you get total retinal detachment, and if it's severe enough, you can have also hemorrhaging. There's also what's known as called plus disease. So some babies with retinopathy of prematurity, in addition to having a stage, they also have plus disease. And plus disease can be, you don't need to have all of these features, just one of them. So if there's significant vascular dilation, or the vasculature is tortuous, that would confer an additional diagnosis of plus disease, ROP plus. If there's vitreous haze, if the pupils are conserved in a restricted position, or if there's iris vascular engorgement, any of these would confer plus. In addition to, so it'd be stage 1 plus, or stage 4 plus, or stage 3 plus. Okay, so here's stage 1. This is your demarcation line. So you can see you got relatively normal vasculature here, but a demarcation line present. This isn't a ridge. This is just a line. So here's stage 2. You can see that this is a ridge because there's this is 3-dimensional, so it's kind of, I don't know, it's kind of hard to see. I have to take my word for it, but this is more 3-dimensional. It'd be easier to see it if you were looking with the instrument and you were able to look at it from other sides, but this is a 3-dimensional ridge as opposed to this, which is just a line. Here's another example of a ridge right here. And everything beyond that ridge is immature avascular. So here you have a ridge right here. This is kind of a closer up view. And then you have that fibrovascular proliferation where you have a lot of little small arterioles growing around that ridge. And that's from the VEGF. So here's another example. Here's a ridge right here. And then here's the proliferation around that ridge. So stage 4, you start to have retinal detachment. So this is partial retinal detachment here. I believe this would be a ridge right here, and you have some detachment here. And the detachment kind of looks like a cloudy, opaque sort of appearance. It's just the retina detaching from the supportive tissue beneath it. Here's another example of retinal detachment here. You can see what may also be possibly some hemorrhaging starting to develop. And stage 5 is defined by total retinal detachment. You can see the retina has been pulled away from the underlying tissue. So for diagnosis of retinopathy of prematurity, though leukochoria can be assigned, the best way to diagnose ROP is to screen at-risk infants with a dilated fundoscopic exam, and these babies will be referred to pediatric ophthalmologists for assessment and for the exam. So the guidelines are that all babies born earlier than 30 weeks of gestation will be screened with the fundoscopic eye exam. All babies born weighing less than 1,300 grams, which is about 2 pounds, 13 ounces, will be screened with the fundoscopic eye exam. So beyond that, babies that are born between 30 and 36 weeks, and babies that are born weighing between 1,300 and 1,800 grams, and 1,800 grams is about almost 4 pounds, those babies will be screened if they received supplemental oxygen. And then any baby that's received prolonged supplemental oxygen exposure that was born preterm should also be assessed for ROP. So these are the guidelines. And these babies will get referral to ophthalmology and dilated fundoscopic eye exam. And the ophthalmologist will be able to make the definitive diagnosis whether ROP is there, and if so, what zone it's in, what stage it's in, and what the follow-up should be. And this exam should be performed by 5 weeks of age. A lot of premature babies are in the hospital for some time, and so they may be in the hospital longer than 5 weeks, so you may have that baby in, you need to perform the exam by 5 weeks of age. So the treatment for retinopathy of prematurity, if it's stage 1 and 2, they can be observed with regular exams every 1 to 2 weeks, and usually stage 1 and 2 will be arrested in that stage and they'll regress spontaneously. And once it's completely regressed, then the baby's considered to be cured or no longer have ROP. Stage 3 and higher need to be treated because it's considered that once you reach stage 3, you will go into stage 4 and 5. So stage 3 and higher is treated with laser ablation or cryotherapy, and what this does is it arrests the vascular proliferation, prevents you from progressing into further stages. And the risks for any baby who has retinopathy of prematurity is the subsequent development of strabismus or myopia, and these babies also have an elevated risk of retinal detachment even if the retinopathy of prematurity regresses. So this is Stevie Wonder. He's a musician, pretty well known, and you probably know that he wears these glasses all the time, these dark glasses, and that's because he's blind, and he actually had retinopathy of prematurity. He was born premature, and this was before we had a lot of knowledge that supplemental oxygen is a contributing factor in ROP, and he was on supplemental oxygen for quite some time, and developed ROP and became totally blind. And but he's a musician now. And here is some of his music, and that's the end of our lecture.